It's interesting when the first topic was given initially to me, it just mentioned young Burgess. So I'm going to concentrate on that and just say a little bit about the other classifications. I think the learning outcomes would be to hopefully at the end you can classify pelvic fractures, understand how it helps in understanding and management, and talk a little bit about the role of CT scans. So it's interesting that your first X-ray investigation when you see these pelvic injury patients is a single AP X-ray. And you actually miss only 9% of any significant injuries with just the AP injuries. And it does not change your acute management in terms of requiring CT scans, etc. So your initial X-ray when the patient comes in the emergency department is just an AP X-ray. You don't need to do the other X-rays and CT scans, which were discussed earlier, till you have stabilized the patient hemodynamically. Now, it's an interesting thing about the classification is that it should aid in predicting the hemodynamic instability, in predicting visceral and gastrourinary injuries. It should aid in predicting pelvic instability and understanding the mechanism of injury and the force vectors of injury, and eventually should help you in planning your surgical tactics for reduction of the fracture and fixation. Now, the classifications were many, starting with the anatomical classifications initially, and then the more recent or more commonly used classification, which is probably the most commonly used classification, is that of the Young and Burgess. You have a classification based on stability by tile, and then you have the AO-OTA comprehensive classification. Now, the Young-Burgess classification looks at the mechanism of injury. So you can start with a lateral compression injury, which means the force is from one side of the pelvis, which causes an implosion of the pelvic ring. You have the external rotation injury, which is usually an antero-posterior injury, which causes opening out of the pelvis, which is the so-called AP compression injury. Then you have the vertical shear injury, which tends to vertically displace one side of the pelvis. And then you have combined mechanism where you can't really tell a particular mechanism of injury, which is the cause of the fracture or the injury. The other thing to understand in any of this, in the Young-Burgess classification is, or any classification, is actually the ligamentous structures in the pelvis, which are the most important. So we are looking at the bones, but we are really looking for the disruption to the ligaments. Now, when you come to the lateral compression fracture, where the fracture is from the lateral side, usually the anterior fracture of the pubic ramus is a transverse type of fracture. You can occasionally get a locked symphysis, okay? But if you look at the posterior fracture in the LC1 type of injury, it's usually a compression fracture of the anterior sacrum, and usually means that the force is directed a little more posteriorly. When you come to the LC2 type of injury, you still have the anterior injury, but the posterior injury is usually an iliac wing fracture, often a crescent fracture involving the SI joint. While the LC3 injury, you have a compression fracture on one side, but you also have a contralateral SI injury. So while you have a lateral compression type of injury on one side, the injury on the other side tends to be more like a posterior compression injury. Coming to the anteroposterior compression injuries, you have the APC 1, 2, and 3. Now, APC 1 was initially mentioned that the opening of the symphysis was less than 2.5. APC 2 was more than 2.5, and APC 3 where the posterior sacroiliac ligaments were disrupted. Again, APC 1 implies that it's only the symphysial ligaments that are disrupted. APC 2 then signifies that the pelvic floor ligaments as well as the anterior part of the posterior sacroiliac ligaments are involved, while the APC 3 means the entire posterior sacroiliac ligament complex is disrupted. So it makes this fracture more unstable. And the vertical shear, of course, are unstable injuries where one part of the pelvis is sort of displaced vertically, while you have the combined mechanisms where you can, which the most common mechanism is a combination of the lateral compression and a vertical shear injury. So diagrammatically, you will come to this picture as was mentioned. So the LC1 with the anterior sacral fracture, LC2 with a iliac wing or a crescent fracture, and LC3 with a contralateral injury. Similarly, APC, you just have some opening of the anterior symphysis. In APC2, you have more widening of the symphysis and the floor ligaments are involved, and the anterior part of the posterior sacroiliac ligaments are involved. While in the APC3, even the posterior part of the sacroiliac ligaments are involved. And of course, you have the vertical shear injuries. Now, example of it, here's a lateral compression. Here you've got more like a lock symphysis rather than a pubic symphysis fracture, and you can see the sacral fracture on the opposite side. Here's an APC compression where you can see there's a gross widening of the symphysis pubis, but posteriorly it's more anterior opening of the SI joint. So, and there's no significant vertical displacement. While you have the vertical shear injury where you can see the entire hemipelvis on the left side is shifted superiorly. Now, in terms of resuscitation, so in terms of hemodynamic stability, if you look at the Young-Burgess classification, it's the LC3, the APC 2 and 3, the vertical shear, and the combined mechanism injuries, which are most often would require resuscitation. They also have a higher chance of associated injuries, such as abdominal visceral injuries, head injuries, and vascular injuries. And vascular injuries are most common in the APC 2 or 3 type of injuries. So I think so there's some correlation between the fracture pattern and the severity of injury and the requirement for resuscitation, and also visceral injuries and bleeding. Now, more recently, this is a paper in 2017 which talked about the WSES classification, which is the World Society for Emergency Surgery. And they felt that more than just the mechanism and the pattern of the fracture, it was the overall injury of the patient in terms of the severity. So they looked at the injury severity score as well to try and figure out which patients needed emergency resuscitation. And so they divided them into 3 groups. They had grades, which were 4, which was WSES grade 1, 2, 3, and 4. And then depending on the type of WSES grade, they were divided into minor, moderate, and severe. So minor were the WSES 1 type of injury, moderate included the 2 and 3 grade types of injury, and the severe was the grade 4 type of injury, which was hemodynamically unstable patients. So when they looked at that, so the 2 and 3 came into this moderate category, and these were the ones you would go on to investigate further, do the CT scans, and plan your eventual treatment. While the severe grade 4 injuries, which are really hemodynamically unstable, they felt that at that time there was no real need to do the CT, but to go ahead and do your resuscitative measures, your binder, your packing or embolization, whatever you need, Reboa, etc. And then only after the patient is stabilized, you would go on to more investigations like the CT. Now, just briefly about the tile classification, again, is based on stability. A type are stable fractures where the pelvic ring is stable. B types are partially stable injury where we say that the pelvis is rotationally unstable but vertically unstable. And type C are the grossly unstable injuries. So stability again is dependent on the integrity of the posterior weight-bearing sacroiliac complex and the pelvic floor. So here would be a B1 type of injury where it's an open book type of injury, posterior compression, and you can see there's opening out of the symphysis pubis and anterior opening of the posterior SI joint. So this would classify as a rotationally unstable but vertically stable injury. This type C, where you can see there's opening out of the symphysis pubis, but there's a fracture and a vertical displacement of that entire hemipelvis, which would become a vertically and rotationally unstable injury. Now, in terms of inter-observer reliability and of the Young-Burgess and tile classification, there are a number of studies which tend to show that the Young-Burgess classification has a better inter-observer and intra-observer reliability, which is further improved with the use of CT scans. Although if you looked at the Young-Burgess classification, which first came out in a radiology journal in 1986 and in the Journal of Trauma in 1990, they were based on X-rays. Finally, the OTA classification, which is the comprehensive classification. The pelvic fractures are 61. A is what would come as a completely stable fracture, B incomplete instability, and C is completely unstable fracture. So again, so rotationally unstable and vertically unstable. So you in the type A fractures, you would have things like avulsions of the anterior spine or the ischial tuberosity. In the type B fractures, you would have incomplete, partially stable lesions. So there would be the B type of injury. So B1 would be an external open book type of injury. 2 would be an internal, that is a lateral compression type of unstable unilateral injury. And if this was bilateral, it would qualify as B3. And similarly, C-type injuries would be completely unstable on one side. Okay, so if it was completely unstable on one side, while rotationally unstable on the other side, it would come as C3. While if it was vertically unstable on both sides, it would come as C3. Okay, so C1 would be that it's only a unilateral lesion. C2 would be unilaterally vertically unstable. On the opposite side, it's rotationally unstable but vertically stable. And C3 would be bilateral vertical instability of the lesions. Okay, so that is the classification that we need to look at when we are dealing with pelvic fractures. Now, where does CT, of course, we all know that CTs are important, but basically, apart from the X-rays, which we talked about in detail in the earlier talk, you need CT scans for the details of the injury. It gives you a three-dimensional picture and imaging of the injury. Posterior injuries are difficult to make out on X-rays. Undisplaced fractures may be difficult, and combined pelvic and scapular fractures are difficult. So just to look at what details it provides you, there's an open book type of injury in a patient. Just a second. Sorry about that. Phone had to ring at the wrong time. Okay, so open book type of injury. And so this gives you more details. It shows you the details here. That's the sacrum is intact. You've got an opening of the anterior part of the SI joint here. And you can also see that there's some ligamentous injury with bony avulsion from the sacrum here involving the floor of the pelvis. So these are the details that the CT will give you. Here's an elderly patient who first presented to me with this X-ray. This is some years ago. And then we got the inlet and outlet views, and that's what it showed. But eventually it's the CT that really showed us that there was involvement here, but there was also involvement like a crescent fracture on the opposite side. And she also had an acetabular fracture on the same side. So these details, which are difficult to make out on conventional X-rays. The other useful thing in the CT scan is to look at if it's done in your own institution and you have the PACS system, it's good to see it on the console. You can see the moving images which start off at the lumbosacral spine, come down towards the pelvis. And as you can come down along the way, you can see how the sacrum is involved here. The fracture goes down extensively onto this side with some displacement of the SI joint. And as you come down lower, you can see the crescent type of fracture on the opposite side. You go down further, you come to the level of the hip joint. Okay, so you can see any injury in the hip joint as well as you come down further. As you're reaching down to the area of the hip joint, you can see the head appearing here. And you can follow the scans down carefully and actually map out the fracture very carefully and look at them in detail. So you can see as we go down, there's some involvement of the acetabulum there. And of course, this patient also had a subtrochanteric fracture on that side, which you can see lower down. You can look at the coronal sections again in the same way to look at the fractures. They're coming from anterior to posterior. And then you can see the 3D scans, look at the various angles at this 3D scans, which gives you a very good picture. But if you scans, some of the details get lost in the reconstruction into the 3D scan. So it gives you an overall picture, but not as good in details as your 2D scan. So I think I will stop there. Just to talk a little bit about some of the issues with CT scans. One is that today with the use of the pelvic binder, don't rely on your initial x-rays completely. So this is a case report where a patient had CT scans, the x-rays were normal, and they actually felt there was no significant pelvic injury till about 2 days later when the binder was taken off and the patient started complaining, and they did an x-ray without the binder, and you can see there's an opening out of the symphysis here, and posteriorly there's opening out of the SI joint as well on the anterior side. So it was a grade B type of injury which they would have missed if they hadn't done the x-ray without the binder. And also more recently they've looked at mathematical sort of equations and okay, so take home pelvic injuries can be serious life-threatening injuries. I think the classification should indicate severity of instability in these injuries and should also guide you on the management of these injuries. And of course, the role of CT is important in assessing the nature of these injuries completely. Thank you.